I don't know. Maybe it's the theory of better late than never for this conversation.
The Dan York State of Mind program is brought to you in part by Lookout Rhode Island and Taco Comfort Solutions.
So on Friday evenings, we kind of focus on a single issue. I think if you've been a viewer of the program for the almost, guess what, coming up in a couple months, 4 years that we've been running this operation, you probably know that we forego any kind of skipping around on a rundown of the issues of the day and kind of tackle a significant issue. We have two advocates on one side of an issue today, but I think they've got enough perspective to offer at least the angles of the argument. And what's interesting is that while we scheduled this show a handful of days ago, the governor just more or less clamped down with the signing of the bill that our guests don't like very much. First, here's Governor Raimondo. So welcome in, by the way. Nice to have you on this hot, humid Friday night. Here's the governor at the National Governors Association conference talking about the opioid crisis.
We have a prevention campaign, which we're about to kick off. We have done medical assisted treatment using our Medicaid money for that, particularly in our prison system. A little bit controversial, very effective.
Okay, and here's the headline from yesterday, which is she signed a bill that these two guys don't like very much, based on the radio conversation I had with both Steve Brown from the ACLU and Steve DeToy from the Rhode Island Medical Society. Just checking the semantics of that. You're not very happy, are you? Welcome, guys. Nice to have you.
Thank you.
You said something prior to the show, Steve, that I think is probably on target. Now it was a what was it that you said?
It was a theoretical bad idea, and now it's an actual bad idea.
Yeah. So let me be inquisitive rather than opinionated on this here this evening. My instinct is that these guys have a hell of an argument, but for some reason it's been lost on the Attorney General, who has been kind of fighting these guys and actually personalizing the argument in some ways, which I think is very strange and probably not good business. And I think I understand the governor's politics. Let's start from the beginning. What is the beginning of this conversation? It's the opioid crisis, is it not?
Yes.
For the most part?
Yep, absolutely.
So I think the governor's going to do everything she can to keep putting in programs that fight the opioid crisis because A, is politically prudent and conceptually the right thing to do. Your society, representing the docs, thinks that you've done enough, or I should say, on track to what? Let me not put words in your mouth. Okay,
well, first let me say not just the docs. There were 21 organizations that signed on to the veto request letter to the governor.
Okay.
It's not that we think we've done enough, because certainly we haven't. We still have a lot of people dying. But we've, to this point, attacked this issue as what it is, a medical problem, not a legal problem. And some of the stuff the governor was talking about at the NGA are all very innovative and creative approaches that we're doing here in Rhode Island that many states are not doing. We have some first-time firsts all over the place, and we've been a very active participant in working with the General Assembly and the governor on those issues, dealing with the opioid crisis, because after all, addiction is a medical problem.
Right.
And now we've ventured into allowing law enforcement to insert itself into the prescription drug monitoring program, which is by design a medical decision-making tool.
Got it. And so I really should spend some time explaining, or have Steve Brown do it because he gets this stuff, good lawyer, what this bill is. This bill, and be as objective about its description before your subjectivity on your argument comes in, if you could do that for me.
Sure.
The objectivity on this whole thing, the bill is designed to do what?
Well, let's take a step back and talk about what program we're talking about. The Department of Health has a database. It's called the Prescription Drug Monitoring Program, or PDMP. And at this point, what that database has is every prescription that a doctor or other person in Rhode Island writes out, a pharmacy fulfills. That information goes into the database.
For controlled substances.
For controlled substances.
Meaning?
It is.
Meaning the Vicodins and the Percocets and...
Well, those are Schedule 2, and that's where we started. But we're now up to anti-migraines, anti-seizures, psychiatric drugs, all the way to Schedule 5, which is basically codeine with Tylenol.
Oh.
So it's a very large...
Okay, so it's grown.
Yes.
Why is it grown, by the way?
Because it started, the original grant from the Department of Justice was to set up a monitoring program, and again, monitoring from a medical standpoint for opioids. That was the grant that the money came out for. 3 years ago, Steve, 4 years ago, the Director of Health at that time, Dr. Fine, wanted to expand it to collect all the controlled substances. And by the way, there was legislation this year where we're now also going to be collecting information on prescriptions for naloxone.
All right, so it's grown, but you were saying?
Yeah, so it has all of this prescription information.
This registry, this database.
Right, that, as Steve said, was designed for medical purposes to help monitor what doctors are doing, help doctors themselves monitor, whether there are counterindications for, who's taking how many drugs, what sort of drugs. And when the program was expanded 3 or 4 years ago to start including these lesser prescription drugs, just about everybody at the time agreed there needed to be some safeguards in place. Once you're now having this huge database with all this personal information, there should be some safeguards. And one key safeguard was saying before law enforcement can gain access to any of this information, they should get a warrant. They should go to a judge and get a warrant. At the time, the Attorney General did not like that, but the legislature and the Department of Health all agreed that this was an important safeguard. If we're going to start using this database to cover just about everything in the world in terms of controlled substances. Since that time, the Attorney General has put in legislation to try to repeal the warrant requirement. So I disagree slightly with Steve about whether the opioid crisis is really what drives this. This is something the Attorney General has been pushing for before the opioid crisis was the big
What would you
public
suggest
deal.
his motive is for that?
I can't deal with motivations. I think one of the things that has troubled me from the beginning is that here we are 7 months after this bill was introduced this session, and I've yet to hear one cogent argument as to why it's necessary. It's always presented as if or. If we don't have this access, then we can't get it, and that's not the truth. They've always been able to get access to this information with a warrant.
And they can also get access through the Department of Health because as part of the regulatory review of the prescription drug monitoring program, if the director comes across something that looks suspicious, she's almost duty-bound to report that information to law enforcement. So they really have two angles in which they can get that information.
Right. And there's been no evidence that I've heard in all the hearings as to why that hasn't worked. Why the Department of Health being able to initiate investigations hasn't worked, why having to go to court to get a warrant hasn't worked. That has been completely missing from this entire discussion.
Well, this is fascinating. We never, we didn't get a chance to touch on that point last time we talked on the radio. So, would it be fair to suggest that the politics, and sometimes the appropriate politics of opioids, and the worry about that, is one motive on one political level, but law enforcement always wants everything. I mean,
yes.
That's why the American Civil Liberties Union, which I used to say Steve Brown batted 200 with me. Lately, he's like at 600 or 700. I don't know, maybe it's just the cycle of it. But you're there to protect the interests of the citizens. Law enforcement's there to gobble up every tool that they could possibly get to be able to solve crimes or whatever. Maybe Peter Kilmartin is, I don't know, riding the wave here of the opioid crisis in order to be able to get something done, while Gina Raimondo is just trying to show that she's responsive to the opioid crisis. Feel free to disagree with the guests about...
I'm also not going to get into the motivations, but I think one possible explanation is we all feel a great frustration on the fact that we are doing so many things on so many levels, and the number of deaths from overdoses continues to go up. But the number of deaths going up from overdoses going up because of fentanyl into the system. That's a legal law enforcement issue, stopping the supply of fentanyl. The amount of overdose deaths attributed to diverted prescription drugs, which I assume is part of his motivation for this, is the least common reason that people are overdosing.
Okay, hold your thought there. We're going to stop here because there's some definitions and Steve just said a lot right there. We got to break that down so you really understand what he's talking about, and then we'll lay out some of the Attorney General's arguments. Stay with us.
In Massachusetts now, you can't graduate from nursing school, dental school, medical school, or pharmacy school unless you take and pass a course in opioid therapy and pain management.
The highly popular governor of Massachusetts. His point is an important one. Your medical society doesn't argue with those kinds of training enhancements.
Oh, absolutely not. We've been part and parcel helping design those.
Okay, so the medical society is saying, hey, listen, we get it. We've got to, I don't want to put words in your mouth, but I think I hear you saying we got to tighten up a little bit when it comes to how we prescribe when I had my teeth pulled and they gave me a Vicodin, I took one and said, never again, and it sat on my shelf until I could figure out where to dispose of it at the police station. I mean, that's, I probably could have sold those Vicodin on the street for gosh knows what, right? So that's the diverted medicine that you were referring to. And I think it's important that you help us quickly define some paths of this medicine that ends up being exhausted, and then we get into the heroin thing and the fentanyl thing and the heroin and all that kind of a thing.
So first, let me go back to disposing it at the police station. That was a piece of legislation the Medical Society wrote and got introduced.
It was brilliant. It's brilliant because you don't know what to do with it. You're certainly not going to send it. You don't throw it in the garbage or the toilet bowl. Don't do that.
So, what was the question again?
Well, the point is that you guys have stepped up to try to tighten up. Docs don't just. They understand now that the pain medicine is not only being misused by patients who may be cured, but being sold on the market and all that kind of a thing.
And that's probably where we were 3, 4, 5 years ago. And first of all, let me say that the prescribing professions clearly have acknowledged our role in helping to create the opioid crisis. There's no doubt about it. We're committed to being part and parcel of the solution. So that type of diversion was more rampant back 3, 4 years ago. We've tightened that up. Since 2013, Rhode Island prescribers have issued 24% fewer prescriptions over that course of time. That's second only in the country.
And this is kind of reference to pill mills. I had a frustrating day the other day because here you and I were talking about this, the three of us talking about this on the radio, and we're still newsy kind of talking about pill mills, and you're explaining that was a problem in other regions of the country, but there's no real evidence that there's any existing pill, at least from a doctoral point of view, we haven't seen any pill mills where doctors are illicitly out there selling drugs.
Well, they wouldn't be able to sell it. They'd be perhaps selling a prescription. There are states in the union where doctors can dispense from their offices, but Rhode Island is not one of them.
So we don't have a pill mill problem per se.
Well, this goes back to what Steve was saying. We haven't seen the problem that this bill purports to be the solution to.
But the pill mill term has been used a lot.
Absolutely. It has been used all over the place, and as Steve said, it's, again, without any basis. We need to get at pill mills, is what we've heard at all the hearings.
And you're going, what pill mills?
Yeah.
Right.
Okay, but listen, let's not kid ourselves. People are dying from heroin overdoses out the wazoo, mostly because their prescriptions are running out and they're hooked.
Or they're not seeking prescriptions in the first place because they're concerned. One of the issues that some of the medical professionals raised at a news conference we held a few days ago, urging the governor's veto, was that this bill, this now law, might actually have the exact opposite effect of what's intended. That it may discourage some people from going to a doctor, that they will just go the illicit route because they know they're concerned about having their name in a database and being subject to law enforcement investigation.
Sorry. Addiction is a mental health disorder. It does not necessarily mean that you started on Vicodin and you were a gateway drug into heroin. That has happened. It happens a lot. But if we've learned anything about the war on drugs, as long as there's a demand, there will be a supply. And the supply, we've tightened up the demand or the supply of prescription drugs that can be diverted. So now people go to the street. Once they go to the street, they have a great potential for overdose. If they go to the street and get fentanyl, they have a great propensity to die because you don't often I'm not sure you even can survive an overdose of fentanyl.
All right, but that is, to your point, a law enforcement issue.
Well,
Yep.
because those are illegal drugs.
Yeah,
nobody's arguing
it's
about
the second
that.
time I've used this term, for major discussions. One was the budget the stalemate between the Speaker and the Senate President, where I called the amendment to the budget a red herring. It almost feels like this bill is a red herring, in a sense that it tackles something that doesn't necessarily need to be tackled. That there's no pill mill crisis. The medical society has tightened up its behavior when it comes to prescriptions. So what are we doing here?
Yeah, I can only think of two arguments. One is it's more convenient for police, and that's true. Anytime you don't have to get a warrant, you can do it yourself.
Yeah, but let's be clear about this.
That's convenient.
If I understand Steve correctly, this bill it's authorizing. I've got
certified. Right. So so-called certified law enforcement investigators.
FDA, DEA, FBI, Office of Health and Human Services, Office of Inspector General, and the AG's Medicaid Fraud Unit.
Right.
They are the ones that don't need a warrant now.
Correct.
But still, local and state police need a warrant.
Yep.
Yes.
Yes.
Okay, so
unless they go through one of these
folks,
they can go through one of these people to do their work.
And
for
you
them.
think that'll happen a lot?
It wouldn't surprise me.
They would accelerate their work simply by using other.
It creates that possibility, at least. There's no question about that. So you don't want to get a warrant because it's a lot more convenient if you can just pick up the phone or fill out a piece of paper and give it to somebody and say, we want these records. I don't think convenience is a compelling argument for such an incredible invasion of patient privacy. And then the only other argument I can come up with is it's a way to encourage or authorize fishing expeditions. You can't get a warrant for a fishing expedition. You have to have probable cause of criminal activity and convince a neutral judge that you have grounds to do that. If you're able to just sign a piece of paper saying I'm engaged in a drug investigation, here's a case number, give me this information, you can pretty much do what you want.
All right, when we come back, we'll remind you what the AG has had to say about this. And now that the bill is signed, what are you going to do? Stay with us. All right, there's the Attorney General, Peter Kilmartin. He's had some statements on this argument that the Medical Society and the ACLU are making against this bill that Governor Raimondo has signed, and so it may be spilt milk at this point, but he writes, the scare tactics by the Medical Society and others are disingenuous and outright lies. Maybe the question ought to be, what are the doctors trying to hide? That's one thing, and I'm sure Steve DeToy's got some answers for that. The second would be, the bill requires each public safety agency to submit to the Department of Health quarterly reports. In other words, this is all going to be just nice and tidy. I don't know what you guys are worrying about. Deeper in his statement as well, he talks about Mass and Connecticut, who seemingly have this kind of bill, that we are duplicating what our next door neighbors are doing. First of all, the whack on the doctors, you can react to that.
I think that the Attorney General's comments are way over the top. They're personally insulting to the medical profession, the dental profession, all the other professions that have prescriptive authority and have been part and parcel of working for a resolution and working with the governor's task force to deal with this opioid crisis. It's beneath, I think, his office to make those kind of allegations, and they're just not factual.
And in some ways, I think maybe they're acting out a little bit because doth protest too much, perhaps. I mean, it almost seems like a complete overreaction. Yes?
And again, it doesn't address the merits at all. I mean, it's name-calling, which doesn't really tell you much about the substance.
All right.
I think the only difference is he didn't tweet it out like some people do.
All right. Well, here's the thing. Don't get me started on social media. There's a nuance here with the Department of Health, though, that you wanted to talk about real quick, about what happens with this information. And if you just tuned in, you got to go back to the beginning of the show at foxprovidence.com or watch at midnight if you're watching at 7:30, because this is all about a bill signed by the governor that allows for this database of medical records for drugs, prescription drugs, to be literally purged by numbers of layers of law enforcement and administrative types.
So Stephen was talking about how the bill would work and how they circumvent the warrant process. in between the database and that certified letter from a certified drug investigator or whatever it is the Director of Health, who oversees the database now. And she is there to respond to those requests, hopefully to determine whether or not they're valid or not, but that's not really her role under the bill.
What kind of number and volume are we talking about in terms of those numbers of requests?
Well, this is something that
we don't know yet.
No.
Well, we don't know how many warrants they've
One
been
a
denied.
week, 13 a day. I don't know.
She is going to be required to present reports quarterly, I believe it is, to the legislature on the activity. And at the end of every year that this bill's been in place, she will have the opportunity to discontinue, I think is the word, cooperation.
All right, so tell me about the idea that Mass and Connecticut have just about a replicate bill.
They do, but what's missing, of course, is that all the other New England states do require a warrant. So yes, there are two of New England states.
Everyone who wants to get into this database has to have a warrant in the other New England states.
Right, the other
Any
New England states
idea
have laws similar to us.
Why did Mass and Connecticut do this?
You know, again, it may be similar to what happened here. You know, they established a database for a limited purpose. Nobody thinks it's a big deal. And then over time, as happened in Rhode Island, more and more prescriptions are added, but they don't figure out that there needs to be.
Did the Med Society and the ACLU and others fight it in those states as well?
I'm not sure that Mass and Connecticut have the volume of patient records, all the controlled substances there, so there may not be an apples-to-apples comparison. We did not require it when it was first just Schedule II, and by the way, when it was first Schedule II, Vicodins were not part of that because they were a Schedule III drug at that point. So when we moved 4 years ago to expand to all the other controlled substances, that issue came up.
Right. Moral of the story is this: the governor signed the bill. What do you do?
Good question.
I think we will, and
It's been a great show.
I think
Trying to get people to tell the governor not to sign the bill. She signed the bill.
Yeah, the one nuance of the story is, Dan, that this was one of the closer votes in both the House and Senate as we moved through the end of the legislative session. I absolutely think that we will ask someone who voted against it to introduce a repeal for us, knowing that that's probably not going to go anywhere, but that it's something we've got to continue to fight for.
Well, it'll go somewhere when the ACLU has what they traditionally have, which is a press conference with some victim who feels like they have been violated by some, and that, whether that rains or pours or trickles or drizzles, who knows, but generally that's how things change when personal stories of trauma appear.
That's a good example. The problem with things like this is because we're talking about secrets. Patients, unless something actually happens down the road, patients will never know that their records have been looked at. You know, that's one of the problems when you're talking about this type of process.
All right. Well, listen. Be aware. Be aware, guys. Thank you very much for the argument.
Very well.
Appreciate
Thank
it.
you.
When we come back, we'll tell you what happens next week. Stay with us. All right, listen, there's so many social issues that come along with the legislative session, and I'll tell you that folks who advocate for the homeless have plenty to say, and we'll talk about that coming up on the Monday program. Of course, we'll follow the bouncing ball from Washington to Smith Hill and Beacon Hill over the course of the weekend. You have a great weekend. Thanks for joining me. Good night.